histology of liver. So I want everyone to practice this diagram for liver lobule. So once you are done with this liver lobule, what you have to do is, see, this is the way, not even see. This is the histological picture under high magnification. You are finding the same features. You see, this is central vein. Okay, these are all radiating hepatocytes, and in between empty spaces are nothing but the sinusoids, and small biliary canaliculi are only theoretical aspects. Okay, so I said at each border we have portal vein, hepatic artery, and bile duct. So I'll show you one picture which you are supposed to draw. Yeah, this one you are supposed to draw. This is diffuse picture also. So this is the one, the central vein, radiating hepatocytes, then sinusoids. At each hexagonal like end, you will see we have portal triad. So that is all about histology. Once you are done with histology, let me take you to gross anatomy of liver. Visceral surface is asked, right? So liver, you can see, uh, of course, liver and alcohol best friends. I kept that slide because alcohol is damaging liver. We know that. Everybody knows that fact. So that is liver is bed shaped. Now only visceral surface is asked. So what to do? Whether to tell everything or that basic things I'll tell you. So the presenting parts of the liver, it has certain surfaces, borders, lobes, and fissures. So what are the various borders it has? See, this border, which is very much prominent among all which you view from down, is the inferior border. The remaining borders are not so clear. We have posterior superior border and we have posterior inferior border also. Okay, then now our question is visceral surface. Visceral surface is the surface which is seen from downwards. Okay, the presenting parts of the liver are the surface which you see from front is the anterior surface. The surface which is below the diaphragm is the diaphragmatic surface. The surface which you see from down, this has been tilted to show that surface. The surface which you see from down is inferior surface, also called as visceral surface. Okay, on the visceral surface we have many impressions. Nearby visceral organs will just press against it and you will see the impressions. Now this is a very good picture which I have already shown you when we were discussing peritoneum, like lesser sac was this area. Now this is our liver. You can see it is all surrounded by peritoneum. Now lower down, what is the name of this organ? This is stomach. So stomach is showing its impression. Okay, you can see this is pancreas. Pancreas also will show its impression. If you remove the stomach and pancreas, the other side you will see right kidney. Right kidney also will show impressions. Now see here lower down we have visceral surface. So this is right colic flexure, that will show impression. Then stomach outline, it will also show impressions. Pancreas also will show impression. Okay, some part of spleen also will show the impression. Okay, so overall the presenting parts of the liver, it has parietal surface, that is the diaphragmatic and anterior surface. Then we have visceral surface. Okay, so we will focus on visceral surface more. Even this dissected body also will give you an idea like how the liver is placed. See, you can see two lungs in between heart. You are seeing this is a diaphragm. only part of the liver is seen. So below this is the inferior surface of the liver, and so many visceral organs are there which will be creating their impressions. Okay. So now let us see the visceral surface. Then yeah. So the visceral surface of the liver, it is related to, this is right lobe of the liver and this is left lobe of the liver. So it is related to right kidney. Over the right kidney, we will have the impression of right suprarenal gland. Okay. Then so we have impression for stomach, then we also have impression for duodenum. This side is right lobe, no? So we have impression for right colic flexure. This is the impression for gallbladder. So we have two small other lobes other than right and left lobes. What are those? We have quadrate lobe and caudate lobe. Okay. So very close to the caudate lobe, we have ligamentum venosum. Okay. And very close, now see here, very close to this inferior vena cava, there is one more ligament actually, that is here you have ligamentum teres. Okay, fissure for ligamentum teres. This area is porta hepatis. Porta hepatis in the sense the area which allows the entry and exit of structures. So what do we have there? We have bile duct, we have portal vein, and we have hepatic artery. Okay, that area is porta hepatis. Okay, so all these are the impressions. So this is the visceral surface of the liver. So we have right kidney, right suprarenal gland, stomach, duodenum, right colic flexure. Okay, caudate lobe, quadrate lobe, ligamentum venosum, ligamentum teres, porta hepatis with portal vein, hepatic artery, bile duct. At each corner of hepatic lobule also, these names only came in histology: portal vein, hepatic artery, bile duct. Okay, so all these are the visceral surface impressions, which is asked for your essay question now. So describe the visceral surface. Development part we will study when we do embryology. If any slide is here, I'll help you with that. It's simple only. Again, see, the clinical way of framing of question will be, it can be something like this: an alcoholic person has come with uh, hypertension where the liver is completely damaged, or some clue or hint will be given better. Okay, so we know like alcohol is responsible for the damage of liver. It may lead to a condition called as like portal hypertension. Okay, this portal hypertension will lead to varicosity of veins around the umbilicus. You call it as caput medusae. It may lead to ascites. Ascites is a condition where you will see accumulation of fluid in the abdomen. You should have seen alcoholic people will have pot belly like this. Full abdomen will be protruded. Okay, cirrhosis. Okay, the normal liver is replaced by fibrous tissue, that is called as cirrhosis. Gradually, it may transform into cancer. Okay, so that is so that is all. I will discuss the embryology later. Coronary sinus I already discussed when we were doing venous drainage of heart. I said what are the various veins draining into the coronary sinus? Great cardiac vein, small cardiac vein, isn't it? Anterior cardiac veins, oblique cardiac veins, all the venous network of the heart is opening into coronary sinus. Where is the coronary sinus opening? Coronary sinus is opening in the right atrium. What is the valve guarding coronary sinus? Thebesian valve. Another name is valve of coronary sinus. Okay, this is the largest venous channel of the heart. Internal mammary artery actually came yesterday when we were doing venous drainage, sorry, mammary gland. But despite of that, exclusively I will tell you this topic: internal mammary artery. Where did we see this internal memory artery is a branch of which artery? Can anybody tell me? Internal thoracic artery. See this picture we have seen when we were discussing mammary gland yesterday. So this is arch of aorta. From the arch of aorta, the continuation is subclavian artery. So this subclavian artery on the right side and on the left side, both the sides, it gives one artery which is moving behind the ribs. Behind the ribs it's moving and it is entering into rectus sheath. Do you remember what is the artery we see in the rectus sheath? Superior epigastric artery. Okay. So how many internal thoracic arteries we have? Two internal thoracic. This is right internal thoracic artery. This is left internal thoracic artery, which is seen in the anterior chest wall on either side of sternum bone, breastbone. Okay. Then origin. So this artery is coming from the first part of subclavian artery. Okay. So this is, now see here, which bone is this which is shown like this? Clavicle. The clavicle is actually broken so that you can see the clarity. Even the rib cage is broken to show you that how the artery is going downwards. Okay, the first part of the subclavian artery is giving origin to this internal thoracic artery, also called as internal mammary artery. Okay, about 2.5 centimeters above the medial end of the clavicle. Okay, so this is our thyrocervical trunk. Quite opposite to thyrocervical trunk, you will see the origin of the internal thoracic artery. Okay, then the course, it descends behind the medial end of the clavicle. Okay, then it is going behind the upper six costal cartilages. You can actually count 1, 2, 3. These are all costal cartilages shown in gray color. Okay, it goes behind the upper six costal cartilages 1 centimeter lateral to sternum. Okay, and it ends in sixth intercostal space. And you can see it is now dividing into two branches, isn't it? This artery is finally bifurcating and dividing into two branches. What are those? The one which is going in the rectus sheath is superior epigastric artery, and the one which is going laterally is musculophrenic artery. This is musculophrenic and this is epigastric. This is musculophrenic and this is epigastric. Okay. Then what are the relations? Now see here, this is our internal thoracic artery or internal mammary artery. So the relations are from above downwards, it is related to medial end of the clavicle. Close to this, you are finding internal jugular vein, brachiocephalic vein, this phrenic nerve, which goes and supplies the diaphragm. Okay, pectoralis major muscle, upper six costal cartilages, external intercostal membranes, internal intercostal muscles. All these are theoretical aspects which you see during dissection and which I kept this slide to make you understand. The same thing has been listed here. Okay, those are anterior relations. If you remove this artery, whatever you see behind, that forms the posterior relations. So you have the second costal cartilage, endothoracic fascia, and also the pleura. Okay, then we have sternocostalis muscle. This is the sternocostalis muscle. Okay, so these are the posterior relations of internal thoracic artery. Then if you observe, I told you, if one artery is having two veins on either side, what is the word used? I said vena committens. This I told you when I was discussing some other artery, I think brachial or axillary artery. Okay. So vena committens is the word which is used to represent like artery surrounded by two veins. Similarly, even internal thoracic artery has vena committens. Okay. Then, so corresponding veins, they are named as internal thoracic veins. Okay. So the internal thoracic veins will be draining into this vein, that is brachiocephalic vein. Okay, brachiocephalic vein. Now coming to the branches, we saw the terminal branches. What are the terminal branches? I said superior epigastric and musculophrenic. Apart from that, this internal thoracic artery gives many branches like pericardiophrenik. Pericardiophrenik in the sense you don't read anything. Pericardium and diaphragm. That means this branch supplies the pericardium and diaphragm. Then mediastinal branches. That means it goes and supplies the mediastinal structures. In the mediastinum, we have heart and the mediastinal surface of lungs. Okay. Then we have anterior intercostal arteries. These are two in number. You can see this is first intercostal space between the first and second rib. We have second intercostal space between second and third rib, and so on. So in each intercostal space, if you see, the internal thoracic artery is giving two anterior intercostal arteries. This you will study again when we study intercostal space. Intercostal space is also either short note or essay question. You need to recollect this point when we are doing that. See, internal thoracic artery is giving two anterior intercostal arteries in each intercostal space. Okay, anterior intercostal arteries in each, two anterior intercostal arteries in each upper six are numbered here, upper six intercostal spaces. Okay. Then rest of the spaces are receiving branch from which artery? Musculophrenic artery, which is the branch of internal thoracic artery. Okay. Now, superior epigastric artery. You already know when I was discussing the rectus sheath, I told you the superior epigastric artery is entering into the rectus sheath. It runs downwards. Okay. Behind the seventh costal cartilage, you need not write so much story. You just write it is running behind the seventh costal cartilage. It pierces the rectus sheath to enter, and it is seen as one of the contents of rectus sheath. It runs in the rectus sheath and it anastomoses with inferior epigastric artery. So that means superior epigastric artery and inferior epigastric artery, they anastomose inside the rectus sheath and they supply rectus abdominis muscle. You write in your own words. You need not write whatever is written here also. Okay. So this is superior epigastric artery entering into the rectus sheath, anastomosing with inferior epigastric artery. Musculophrenic is this one. Okay, so which is running laterally from seventh costal cartilage. Actually, the better picture for musculophrenic is this. Okay, at sixth costal cartilage, you can see the final bifurcation of internal thoracic into superior epigastric and musculophrenic. Musculophrenic artery is giving two anterior intercostal arteries in each space, seventh, eighth, and ninth. Okay, the same thing is written here. But muscular. Seventh, eighth, and ninth intercostal spaces will receive anterior intercostal arteries not from internal thoracic artery but from musculophrenic artery, which is the terminal branch of internal thoracic artery. Okay. So this is our internal thoracic artery, also called as internal mammary artery. Okay. So when we were doing coronary arteries, I told you we usually use certain grafts for bypass. I told you we can use great saphenous vein also to just use as a bypass way when the arteries are blocked or very much damaged. Okay. So in such a case, we can also make use of internal mammary artery in the treatment of coronary artery disease. Okay, bypass grafts can be kept like this. So from subclavian artery directly you just give connection to the coronary artery which is working, because most of the arteries, if they are blocked, it is easy route. Directly from the subclavian artery the blood will start flowing to the cardiac muscle. Okay, that is bypass surgery. Okay, so that is all about internal thoracic artery. So after internal thoracic artery, we will do ovaries. Meanwhile, read something, whatever, but don't waste time. Now, ovary and fallopian tubes you are seeing. Where do you see the ovaries? We have already discussed uterus, fundus, body, cervix, vagina, isn't it? And these are the fallopian tubes. So, and these are the fimbrial ends of the fallopian tubes where we find ovaries. Now, ovary are a pair of female reproductive glands which produce oocytes. Okay, they are seen in lesser pelvis. Ovary is completely surrounded by broad ligament. What is the fold of peritoneum which is suspending the ovary called as Mesoovarium, I told you when I was discussing broad ligament. Mesoovarium is the peritoneal covering of ovary. Okay, when you see the gross features, so the size vertical measurement is 3 centimeters, transverse measurement is 1 centimeter, and anteroposterior is 1.5. It looks like an almond. Okay, and axis is this vertical position. Okay, then so position, now we have relations is asked. So now coming to the relations of ovary, ovary is bounded. If you observe, this is the pelvic cavity where the ovary is shown. Fundus of the uterus, you can see these are fallopian tubes. This is also fallopian tube, and here we have the ovary and ovary. So ovary is bounded medially. If you observe, this is the medial. That means this is moving across like this. So medially, it is covered by the fimbriae of the fallopian tube. Laterally, this is pelvic wall. Superiorly and anteriorly, this is superior above. Of course, the intestines have been removed here. This is not in situ picture. Only few things we can see here. So laterally in the pelvic cavity, you will see superiorly and anteriorly, we will have coils of small intestines, and inferiorly, it is actually resting in ovarian fossa. In ovarian fossa. So this area is close to ureter and internal iliac vessels. Okay, in inferior relations. Okay. So now presenting parts also you just try to understand. It has two ends. What are those? The end which is towards the fallopian tube, this is called as tubal end. The end which is attached to this ovarian ligament through the uterus, you call this as uterine end. Then it has two borders. What are those? It has anterior border and posterior border. Then it has two surfaces. Close to the midline, it has medial surface. Away from the midline, it has lateral surface. Medial and lateral surface. Actually, we also call it as upper pole, lower pole, medial surface, lateral surface, anterior border, and posterior border. Okay. Then, so now surfaces. See, ovarian fossa. What did I say? Ovarian fossa is the place where ovary is resting. Actually, boundaries of ovarian fossa is very, very important. So, what are the various structures we find in the ovarian fossa? We find external iliac vein. Okay. Then we also find this is the internal iliac artery. Okay, internal iliac vessels. Then are you finding there is one tube which is coming like this, which is close to the ovary? So this tube is actually ureter. Okay, so we have internal iliac vessels. We also have ureter, obliterated umbilical artery, and lateral wall or floor. We have obviously the peritoneal covering, then obturator vessels, and there is one nerve also passing beneath the peritoneum. So whatever structures you are seeing here, you need to memorize everything, because boundaries of ovary, like the question is very specific. He's not asking every stuff. He's only asking you the relations, like what is present anteriorly, posteriorly, medially, laterally in the ovarian fossa, what are the various structures you see. So that is the part of your question now. Okay. So that is all about ovary and histology of ovary. What do you see in histology? In yesterday's class, somewhere for polycystic ovarian disease, anovulatory cycles, I told you one structure. I'll show you anyhow. Pleural recesses. These are all very short notes. So what are pleural recesses? Can you name them? Are you seeing pleura on the screen? See, the recesses of pleura, as one of our student has told, I could not identify. See here, we have costodiaphragmatic recess and costomediastinal recess. So these recesses are nothing but the extra spaces, costomediastinal spaces. That means the space between the visceral pleura and the parietal pleura. This is the visceral pleura which is closely investing the lung. Parietal pleura is away from the lung. So you are finding some empty space. Similarly, here is a very big space. Here you will have visceral pleura which is closely investing the lung, and this is parietal pleura which is far away. So here you are finding some extra space. Okay, so that means these spaces, the costodiaphragmatic, if it is close to the diaphragm, it has been named as costodiaphragmatic recess, and if it is close to the mediastinum, you call it as costomediastinal recess. The purpose of these recesses are, suppose when we are doing very deep breathing, pranayama exercises, breathing exercises to expand our lungs more. Physiotherapy is playing an important role in treating corona cases. Now we are coming across something like this. What does that mean? That means these breathing exercises will help the lung to expand beyond the normal capacity. The vital capacity will be increased. Okay, we are giving some exercise to the lungs. When we are giving such exercise, you will see the lung will come up to the lower part of the costodiaphragmatic recess. So whenever we are doing deep breathing, which is actually helping us to accommodate at the maximum space. Okay, so that is actually the purpose of recess. Okay, normally the space between parietal visceral pleura is a potential space where we have only serous pleural fluid. Okay, so generally what is the purpose of these pleural recesses? It helps in lung expansion during deep inspiration. We have costodiaphragmatic recesses 2 in number, costomediastinal recesses 2 in number. If you give this much information, draw a rough diagram also, you will get full marks better. Okay, anybody remembers what is foramen of Winslow? Epiploic foramen. I told you there is an opening between greater sac and lesser sac. In front of the greater and lesser omentum, we have greater sac. Behind the greater lesser omentum and stomach, we have lesser sac. There is an opening between two. You call it as epiploic foramen, foramen of Winslow. Okay. We have actually done trochanteric anastomosis, I think, in day before yesterday's class. In the same PowerPoint, we also have cruciate anastomosis. I'll show you. Meanwhile, try to read something. So is it cruciate or which anastomosis which is asked you? Yeah, cruciate. See, cruciate anastomosis, see here, this is the back of the thigh, and these are the branches of femoral artery. So branches of femoral artery, they are actually piercing and perforating arteries. I told you they pierce and they come at the back of the thigh. So these perforating arteries, they are forming a cross-like structure. Okay, like Christian symbol we will have, no, that is cruciate anastomosis. So here, whatever blood vessels are involved, like we had trochanteric anastomosis, right? Similarly, we have cruciate anastomosis. Okay, so what are the, just a minute, I'll tell you. See, where exactly do we find this? At the root of the greater trochanter. You should write all the blood vessels which are taking part in the formation of this cruciate anastomosis. Inferior gluteal branch of internal iliac, medial and lateral circumflex femoral, first perforating branch of profunda femoris. All these are the branches of which are taking part in the formation of cruciate anastomosis. Okay, so tensor fascia lata, it is actually a muscle what we find in gluteal region. Beta, just check, it is very simple. You will have origin, insertion, nerve supply, action. In gluteal region, you will get this muscle. Okay, comes from the iliac crest and it gets inserted in the iliotibial tract. Okay, it is supplied by inferior gluteal nerve and it is like flexor of hip and extensor of knee. The information you will find in gluteal muscles. Gluteal muscles, you will have tensor fascia lata. Okay, so after this we have sinuses of pericardium. See, sinuses of pericardium, we have transverse and oblique sinuses. Anyhow, this will come as a 5 marks question. I will discuss in detail very nicely when pericardium comes as either short or very short now. For now, we will skip this question. So we have genetics question, no? What is that? Bar body. What is bar body? Basically, in females, we have two X chromosomes. Okay, so one X chromosome is actually dormant, it is not working. Okay, it is very much like recessive. And when we just take a buccal mucosal smear and when we just do staining, you will see a darkly spotted structure that is nothing but bar body. Bar body is actually indicating inactivated X chromosome. It is found only in case of females. Okay, suppose if you find bar body in case of males, that shows some genetic disorder. So what is the genetic disorder where we have one extra chromosome with males, XXY? We generally see with Klinefelter syndrome. Phenotypically, the person will be male, but one X chromosome will be there, because of which person will be presenting with feminine type of distribution of hair, gynecomastia. Okay, so tall stature and certain defects, that is for bar body. You can check with your question banks. In any question banks, genetic material is given, whether it is Sia or whether it is Usmania or Falcon. Okay, so I'll show you the histology of ovary and with that we will stop. So what do you see in histology of ovary? Yes, one student was speaking to me, I was very happy. Pleural recess. Who has answered? Shravya?
Yes, ma'am.
Oh, nice. Very good, beta. Histology, can you tell me, beta? Ovary, what do you see? You will learn to. See,
Yes, ma'am.
doctor should speak more and more. You should not have that fear. Right or wrong. First, you should know how to speak. You should convince. That's it. Ovary, what do you see, beta? There is outline. That is the germinal epithelium, isn't it? Then we will have developing follicles.
Tunica albuginea is also present, ma'am.
Yes, beta. I'm trying to share. I don't know if only last 1 minute is there. If it is not able to share right now, also try to please read. It's very simple.